And that leads us then to another little chapter. This next chapter, the subheading is Disorientation and Coma. We're talking about now a post-operative patient who suddenly is not making sense anymore. He seems to be confused, is disoriented, or outright comatose. Let me read vignette 26, a very brief one as a good introduction to this topic. 18 hours after major surgery, the patient becomes disoriented. If this is all that a vignette tells you, no indication as to whether this might be an electrolyte problem, something related to diabetes and blood sugar, something that has to do with liver function. If all you know, post-op patient is now confused, is now in coma, please do me a favor. Look for the answer on that question that says, do blood gases. Because by far the most common reason for a post-operative patient that has no other obvious problems to become confused or to go into coma is if his oxygen isn't getting to the brain. If his brain is not getting the oxygen required, the brain doesn't function well, and that's it. So you want in this particular vignette to say, give me blood gases. Now you might have a question though that makes it more obvious that the problem is in fact the one we're talking about. Let me read vignette 27. In the second week of a stormy, complicated post-operative period in a young patient with multiple gunshot wounds to the abdomen, he becomes progressively disoriented and unresponsive. He has bilateral pulmonary infiltrates and a PO2 of 65 while breathing 40% oxygen. He has no evidence of congestive failure. This is now the complete description of ARDS, the adult, the acquired respiratory distress syndrome. This is a type of patient on whom it happens. It doesn't happen on a patient who is healthy at 3 p.m. and gets ARDS at 4 p.m. The patient gets ARDS has already been very sick for a couple of weeks, like this gentleman. And then we see this picture. The PO2 is very low, even though he's breathing plenty of oxygen, and he's got the patchy infiltrates, but he's not in failure. The key to the treatment, the centerpiece of the therapy for ARDS is PEEP, peak positive end expiratory pressure. We have to be careful when we do it, though, not to use a high volume, because a high volume during this procedure could damage the lungs. It might also help to figure out if he has perhaps a septic process, because often a hidden abscess someplace that hasn't been drained leads to this ARDS picture to develop. Now we move to vignette number 28. An alcoholic man checks in to have an elective colon resection for recurrent diverticular bleeding. He swears to everyone that he has not touched a drop of alcohol for the past 6 months. In the third postoperative day, he becomes disoriented and combative, claims to see elephants crawling up the walls. The wife then reveals that the patient actually drank heavily up until the day of hospital admission. You now realize that the gentleman obviously is having the DTs. He was drinking heavily up until 3 days ago. Now he's not getting any alcohol, and he's gone into DTs. Now the standard management of the DTs lies on benzodiazepines, and that's the answer you should be looking for. But I need to alert you that in the surgical community, we have extensively for many years used intravenous alcohol, 5% alcohol, 5% dextrose, to treat this problem or even to prevent it. And so if you do not find benzodiazepines, which is the standard answer, but you find one of the options to be 5% alcohol, 5% dextrose, in a setting like this one, which is a post-operative setting, that then by default would be the correct answer. Now we move to a couple of vignettes where the problem has to do with electrolytes. So let me read vignette number 29. 12 hours after completion of an abdominal hysterectomy, A 42-year-old woman becomes confused and lethargic, complains of severe headache, has a grand mal seizure, and finally goes into a coma. Review of the chart reveals that an order for D5W to run in at 125 ml an hour was mistakenly implemented as 525. So you know when you read this lady inadvertently got a lot of water into her veins because D5W is dextrose 5% in water. The sugar is metabolized in the body, you're left with water without electrolytes. Now, if a patient simply got a lot of water, that would not lead to a catastrophic situation because if you get a lot of water, you urinate all that water. But if this happens during the postoperative period, at which time, among a number of other endocrine changes, there has been an output of ADH, antidiuretic hormone, then that water is retained. And the clinical picture, in fact, that is described in this vignette is called water intoxication. It's a very lethal condition because you have together the high ADH of the post-op period and the inadvertent excessive administration of water. At this particular stage, with only the description, you need to confirm the diagnosis. So what you want to ask for here is a serum sodium concentration. We assume the patient went to the operating room with a normal serum sodium of 140, and now it's going to be much lower, 120, 115, 110, because the water has been retained, she's become diluted, and it's edema of her brain that is responsible for the symptoms that we're describing, including now the patient being in coma. I'm going to save the management on this patient for a little later on because we have another little chapter coming specifically for fluid and electrolyte arrangement. So we will review this. In fact, we'll read the same vignette again. Let me move now to vignette number 30. We're just putting the emphasis now on recognizing what the problem is. 8 hours after completion of a transsphenoidal hypophysectomy for a prolactinoma, a young woman becomes lethargic, confused, and eventually comatose. Review of the record shows that the urinary output since surgery has averaged 600 ml per hour, although her IV fluids are going in at 100. But this is pretty much the opposite of the previous vignette. In the previous vignette, a lot of fluid was given that the patient retained. In this vignette, we realize the patient cannot retain fluid. She's getting only 100 cc's an hour into her veins, and she's urinating 600. And in fact, when you look at the history, you can reconstruct what happened. An operation was done in the pituitary gland. The intent was to remove the prolactinoma and leave the rest intact, but obviously inadvertently, the posterior pituitary or the stalk have been damaged, and we've created a condition of diabetes insipida. The patient now cannot make ADH, and that's why the water is running out through her kidneys. And again, to confirm the diagnosis, you want to ask for serum sodium concentration, because presumably the lady went to the operating room with a normal value of 140, and now it's going to be 150, 155, 160, a higher than normal value, illustrating the fact that the water has run out of her body. And again, I'll save the management for a little later. And the last of these vignettes where a post-op patient gets confused is an easy one. A cirrhotic patient goes into coma after an emergency portocable shunt for bleeding esophageal varices. In that setting, the problem is a lot of blood in the GI tract. The bacteria in the GI tract are working on that blood, digesting that blood. A lot of ammonium is getting into the blood, and the bad liver that also had the portocable shunt is not metabolizing that.